Well, good afternoon, everybody. We're just waiting for a few more people to join us. We have a few guests that are running a little late. So if you can please just bear with us a couple more minutes. Just as a brief introduction, my name is Phil Newman and I'm supporting the conference today. I'm part of the marketing team from Adapttech. And obviously today we've got people coming from Europe and North America and other parts of the world to join us on this introduction to the Insight system. So let me just check where we are with our guests. Yeah, so we've got everybody here now, which is excellent. So as I mentioned, I'm Phil Newman, and we're going to be joined today by our CEO, Fred Carpetinheiro. Fred will be joining us from our facilities in Portugal. And then from the USA, we've got Drew Buffett of De La Torre Prosthetics and Orthotics, and Cassandra Delgado from POA. So we'll be introducing them properly a little bit later on. But first of all, what I'd like to do is to introduce you to the Insight system. So just to give you an idea of the navigation of the product set. So we have the Insight 3D scanner, which is the unit that we'll be demonstrating for you shortly. That creates a tri-dimensional model of the inner surface of the socket. We also have the biosensor, which is the device that goes inside the socket, which identifies the pressure that is being given out on the socket through the system. And we also have a wearable device which communicates the data to the Insight app, which sits on an iPad. So I'll show you how all of those configure again in just a short while. And really the Insight system is a very optimized system for making sure that the fitting process is really as seamless as possible for both the prosthetist and for the patient. So what happens is the sensors that I just talked to you about earlier, they go inside the socket, as you can see by the illustration there. The socket with the sensors inside is then located inside the scanner, and that tri-dimensional model at that point also locates where the sensors are in real time located on the inside of the socket. And then through the app, the prosthetist will then invoke the scanning process, which will get the 3D image of both the inner layer of the socket and the location of the sensors. And while this scanning is going on, which will take a couple of minutes, the prosthetist can then use the app to complete any of the extra information that's required for the patient session in terms of patient data and so forth. Once the socket is being scanned and placed on the patient using obviously their residual limb, the sensors will provide real-time feedback to the app, as we'll demonstrate shortly. Obviously, the whole purpose of the process is to ensure that the system optimizes the process for the prosthetist and the patient, and obviously reduces the number of socket interventions that are required through the process, obviously speeding up the clinical efficiency for both patient and for prosthetist. So we're going to move on now to running a demonstration of the system. So Fred, our CEO, is currently operating out of Portugal, and he's joined there by our colleague Diogo. And hopefully with the wonders of modern science, we'll be connecting with Fred. Hi, Fred.
Hi, Phil. How are you?
Yes, great. Thank you. Yeah, really good. So are you ready to share with everybody the demonstration today?
Yes, I am. So,
okay.
First of all, thank you all that join us so far. I will be running you through the system, and then in the end we'll have time for a few Q&A. So any doubt, any other question, we'll be able to answer it in the end. So the first step of the demonstration is to start by placing the pressure sensors inside the socket. They've already prepared some of them inside. So here we have our sensors. They are very thin and they have a reusable silicone-based adhesive on one of the sides to make it easier to place the sensors inside the socket. So the sensors are very easy to place inside the socket. You can place as many as you want. We can go up to 16 strips of 8 cells, so 192 sensors. Usually we use 4 strips on below the knee socket and 8 on and above the knee. So once you have all the sensors tucked inside the socket, you move on to scanning the socket. So here we have our laser scanner. It's very simple to use. It only has 2 buttons and everything else is operated from the iPad. So you start by opening the self-centering claw. You place the socket inside. You close the claw to make sure it's properly fixed. close the door. And now I'll share the screen of the app so you can actually see how it works. Okay, hopefully everyone can see my screen now. So basically, we have here our app. You'll have once you have logged in, you'll have the list of your patients, you'll have your user. I've created here a random patient, and I have another that we use for demonstrations just so I can show you some real results since we don't have a patient in our location today. And the first step is to quickly add. We choose the type of amputation and press start, and then we choose press scan, and we will have the scanners on the network. We only have one today, so it's easy. We select it, press scan, and immediately the scanning process starts. So while it's scanning, you can actually fulfill some information such as range of motion, personal information about weight, height, some notes that you want to add in, and you can also take some photos of the residual limb that you want to add in. So in the end, you can actually generate a full report. I have already done the scan takes between 90 seconds and 3 minutes, depending on your network connection. But since I've already done it before, we don't need to wait. So I'll just move on to the results we already have. So here you can see the scan. So it already has here some pressures because I already did an acquisition to try it on, but I'll show you through the entire process. So you can see that we have some little white dots. That's where the sensors are located. So the scanning has two purposes. One is to do the 3D modeling of the inner surface of the socket. The second one is actually to detect how many sensors there are and where they are located, because you can position them freely accordingly to each socket and each patient. So once we have done that, we just grab the socket once again. So then we have our wearable, both units of our wearable device. So we have the main unit that has a movement sensor and the connections for the sensors. And we have a secondary unit that only has the movement sensor. And this is to be used one above the knee, another below the knee, so we can actually see the angles of both portions of the leg relating to each other. And with that, characterize the gait and synchronize that with the pressure information. So we place the wearable facing the outside of the socket. We connect the sensors to the wearable device. So this is a USB-C reversible connection, so it's very easy to connect the sensors. Once it's done, we just turn on both devices. And on the app, we can just come here, add a new acquisition, select the wearables from the list once again, press connect. And if there are any errors, they will appear on that list. If not, we have here the position of the sensors. And if I press the sensors, you can see the colors changing while I'm doing it. So what I'll do today is we prepared something to simulate a fake limb. Obviously, this doesn't work perfectly, but you will see that as I insert the limb inside the socket, you'll get the pressures already changing. So the idea is that if you imagine an amputee walking, you will see immediately the pressures changing with each movement he does. And you can also do a static analysis asking to do different positioning. So you see if I force it on the right side, all the pressure is on the right side. If I force it on the left, the opposite. As I press it down, you'll see pressure on the back and on the front. So what we actually see here, it's our relative pressures. So we are presenting the map of pressures as relative to the general amount of pressure within the socket. So red doesn't mean it's bad. It just means that there is more pressure in that place than in any other place on the socket. So the idea is that you can actually see how the distribution of pressures is, and if it is like you've designed the socket to be. If not, you can very quickly know where you need to do the rectifications and change it based on that. So other features that we have related to the gate that I can also show you, and for that I'll use another patient that we have here. So if I just enter on a previous patient, you will be able to see that you can do static analysis, but if you do a dynamic analysis, you can have the processed results. So you have the average pressures within the socket in the loading response, mid stance, terminal stance, pre-swing, and swing. You can also measure the socket, the internal dimensions very easily. With our tool, you can see the perimeters at different heights. You can see the average stride. So in this case, you'll have the average stride for all the dynamic analysis you did. And then you also have the unprocessed results where you have an animation of the patient walking and the pressure changing with that patient walking. You'll also see that we can detect turns. So once it stops and it's turning, we have a little arrow on the bottom saying the direction of the turn. So the idea is that you can all, and we have seen that that is very helpful, and Drew and Cassandra can probably tell you a little bit more about that, is that after you do this analysis, you can actually discuss the results with the patient, and that helps a lot with for the patient to understand what's happening and better explain what he's feeling, and also to tell them how they should take care of their prosthetics and manage their number of socks and so on. And it's pretty much it. Then you can also export reports, very easy. You just press, you immediately generate the report where you have all the different phases with different angles and your notes, your photos that you can ideally attach to your insurance claims or keep it as a register for your patients. And you will have all the results saved on the app, on the cloud. So you can actually access to any appointment you did with that patient and compare previous results with current results. So everything is very simple to use. Everything was implemented with the standard iOS tools. So everything was done to be very intuitive and very easy to use. And that's really, there's not much more to tell you about the system. I'll be here to answer any questions later on.
That's great, Fred. Thank you. Well, that's obviously, we had to have a patient with us today because of the restrictions associated with COVID, but hopefully that gives you an idea that the dynamic process of fitting and the patient wearing the live prosthesis and giving that live data back is very important in the clinical facility. So obviously, as we've talked about, the benefits for clinics is that this provides an opportunity for optimizing workflows. So this is meaning that there's going to be less time for the prosthetist and less time for the patient in the clinic, and obviously less visits for the patients, which provides obviously that benefit for the clinic and the clinic owner. Of course, the patient outcome is going to be improved. We're going to share some patient information with you shortly. But likewise, the data that Fred's just been sharing with us there, of course, is electronic, and that means that can be associated with patient records and also provide information in the US, for example, for insurance claims and insurance patients. So the digital element is very important with this, but of course, it's the cost effectiveness of the workflow that's going to be very key. So I'm just going to talk about the next stage of that, which is really the benefits for clinicians. So I guess one of the questions that we've had a lot is, are we replacing prosthetists? And the answer actually is no. What we're looking to do is we're looking to increase the workflow for prosthetic clinics. So really what we see is that there are fewer visits for patients, which means that really helps the workflows and obviously means less fabrication time as well. So on the next slide, I'm just going to briefly detail what the patient benefits are. Obviously, we're going to talk about pain in a short while, but obviously going through some of the earlier stages of the socket fitting process, there can be some sensitivity for them. So it means that obviously the fewer interventions that are required, the less pain they're going to experience. Of course, the dynamic element means that the sockets can be adjusted quite quickly within the clinical facility. And of course, really what it means is that the patients can actually see where they're experiencing their issues. So the visual information and the pressure information that's provided, really we found from the feedback from patients too, has been that they can actually effectively see their pain, as one of them said to us, which is quite interesting. So we're going to be sharing some case studies, and we're also going to be speaking with our two prosthetists. In the latter part of last year, we started shipping our certified product into the USA. And we had two clinics that were taking part in the early engagement with the technology in a professional clinical environment. So we're going to share some of those user experiences with you now. So I'd like to introduce our first guest speaker of the day. Drew Buffett is joining us there. Are you there, Drew? There he is.
Yes, good morning and good afternoon to everybody.
Hey, Drew, how are you doing?
Good. Thank you. Thank you for having us and hosting us. This is great. So
yeah, perfect. Well, we're gonna go through some slides, obviously, Drew. I just wanted to just make sure that you're aware that there's two more slides coming up. One is an intro visual slide, and then we've got you actually with your bio. So I'll hand over to you now, and we'll speak in a short while.
Okay, thank you, Phil. Appreciate that. Just once these slides come up, I won't go over the bio in its entirety. Just kind of give you a little bit of background on myself. Been in the field since like 1986, worked out in Washington, D.C. at the National Rehab Hospital under Al Scott at NASCOT for several years. Then they went down to Virginia, Hampton Roads area with the Riverside Rehab system down there. So I was director of O&P department down there for a while, and then came to Pittsburgh with Delatory O&P since 1992. So I've actually been with them for 27 years, which is hard to believe. Time just gets away. Had my 27th anniversary on April 1st, which was kind of a running joke inside the company. But nonetheless, I've seen a lot of changes throughout the years, and we've been trying to keep up with technology to enhance the fitting process. So when Fred approached us to see if we'd be willing to participate in this study, it was pretty much a no-brainer. It's kind of a connection through Carnegie Mellon University. And so we also have a gait lab, and we have a CAD system, which we incorporated into our practice probably about 3 years ago. And so this was just a really nice fluid introduction into this concept. Of course, we're always looking for outcomes. We're always looking for ways to make the fitting process more efficient, to get the patient more involved, to get better feedback. So when they approached me about this particular device and the system that they had, obviously we jumped at the chance to participate in the study. And so it was a great learning experience for myself and a couple of the other clinicians that got involved. So with that being said, there were some really interesting things that came out of it. And one of the things that was very intriguing to me going into it was that the scanner itself, we do have a digitizer, and we do see patients, we manipulate the check sockets and we redigitize those check sockets. And so we're able to save it into the software under their file. And the nice thing is we can capture those changes that we made. Now, there's been a handful of cases where we cannot digitize and we can't capture those changes, particularly some of the odd shapes that we get. So the fact that this scanner is a non-contact scanner, that you saw how Fred did place it into the machine, and the scanner drops down inside the machine and goes to the distal end of the socket and comes back out. So it's a laser versus a contact like the digitizer we have. So for us, the fact that we could and will be able to adapt that and to scan those particular sockets that we were missing before just adds to our CAD system. So it's just an enhancement of the system that we already have. And on top of that, you have the outcome issues that you can deal with. And also the fact that you have immediate feedback from the patient. You can actually, when Sandra and I, I'm sure the same experience, when the patient was walking, I followed them with the laptop and they could see the pressure areas through the gait cycle at heel strike, coming off, toe off. And so we did a recording of every time they took a stride. And it was fascinating to the feedback that the patients gave in particular, that they could actually see what was going on in the fitting process, getting engaged with it. Because a lot of times in the fitting process, obviously we take our own skill set. It depends on how we were taught, where we were taught. Of course, I got involved early with the PTB sockets, and that's progressed to a total contact. And now there's, hybrid socket designs out there as well. So we're always kind of guessing in terms of the pressure areas. And, we rely on our own skill set, on our own feedback, on the feedback from the patients, and obviously on skin contact. And once they wear it, we look at their skin and we kind of discern that. Now, there are cases where you have neuromas. You have patients that when they do the flap and the nerves have been pulled down and just snipped, and they go back into the residual limb. Nobody knows really where they are, and you're getting feedback from the patient, and they may feel like they're getting pressure in one area of the socket, and you realize after you palpate that it's not even close. And so you're trying to chase some of these things, particularly over bony prominence as well. So the experiences I had, with the patients was just, it was an eye opener. I mean, the whole idea is to try to save time. I mean, we, from a reimbursement perspective, in O&P under the L code system, that we're all part of DME. No matter if we see the patient 3 times or 30, our reimbursement's pretty much the same. We have 14 different contracts with the different insurance carriers. So on our side, I'm talking in the US here. So it's just, one of those things that we try to make the fitting process more efficient. And then we need to utilize our time. And Phil was talking about this, was that, if we're spending hours and hours and hours chasing fits, then we can't go on to the next patient, and we can't, increase the referral base and things like that. So the nice thing about this is that, if a patient had a particular problem area, we could pinpoint it, and we could, from a guessing perspective, what we've always done in the fitting process, but then we had some actual feedback and some visualization of what we were trying to accomplish, whether it be a more of a hybrid socket or a, total contact system. So jumping into the first case, Ken Weedaw, I don't want to, I want to read everything because basically the case is before you, but this gentleman was in a traumatic accident, crushing his ankle, but they had to fix it over the years. He had multiple surgeries. Ultimately, the surgeon said, look, Ken, you're going to walk with a bum leg the rest of your life. I think the best thing to do would be to go ahead and have an elective amputation. And so, he did. Now, he doesn't regret that decision. He was in chronic pain before this amputation. And he basically was, just wanting to get back on his feet, get back to work. I got involved a little bit after the fact. These 2 first cases that I'm talking about pretty much were patients were. We started the trial with Adapttech, and then I was able to get them plug them in. And then we've also had cases that they were, fairly new to the system. So in Ken's case, he has a fairly cylindrical residual limb, fairly fleshy. He goes around 240, 50 pounds. Big, robust gentleman. Once you can see the picture, he just finished, I think, a one. But bottom line is, he had, when the surgery was done, he had on the very, very distal tip of the tibia, he had an invagination. And so it was threatening to open up under weight bearing. Of course, gravity's pulling you down in the socket, opposite in the socket, and stretching out the skin. So the clinician prior to myself had him in a pin system, and as everybody is pretty much aware, the pin system, through the swing phase, you get a lot of elongation, even though they had him in a really nice firm liner that had a matrix in it. But he still was getting a lot of elongation through the gait cycle, through swing phase. And so that was pulling on that invagination, and was just, wreaking havoc. He was always getting breakdown, a lot of seepage, things like that. So when we transitioned him over to the negative pressure, had much better results. We were able to do a custom distal pad on him. But the problem, again, was that, there's always that fine line between having too much contact in the socket and not enough. So this particular case, I was able to get in with the check socket, do the sensors, and then, make sure I had a total contact socket. But also I could see that I had more distribution of weight up through the upper 2/3 of the socket, and distally, particularly on that front anterior distal aspect, I was able to unload that. And so I ran the sensors right down through that area, and we could prove that he was still getting contact, but he wasn't getting too much contact. And I know that's always a fine line, but once we were able to determine that on the check socket phase, get him into his definitive, then things really started to pick up for him. That basically took care of the issue, at least for that point in time. And he went for months and months. We fit him with a running blade, and he was able to do some more higher end activities. And with a negative pressure socket, we couldn't go elevated vacuum on him again, just because we had to make sure that the invaginated area was being taken care of. So ultimately, I mean, he did great for a long time, and I think most practitioners understand that once things start to atrophy even more and those invaginations, start to pull open, and he had to go back in and get a revision done, but it had nothing to do, with the fitting process that we did with Adapttech. It was more just the maturation of his limb, and we were able to at least solve that problem initially and get him up on his feet and moving again. So for him, it was just fantastic to see the pressure areas so that he felt confident that he wasn't getting too much pressure, because he didn't have a lot of sensation. A lot of our patients don't. You ask him, can you feel this pressure down there when you palpate certain areas? But he didn't have a lot of bony structure area. I mean, his limb was fairly fleshy and cylindrical, like I stated. But we were looking at one particular area, and we were able to pinpoint that and relieve it. So I think that's pretty much the gist of it, of Ken's situation. We can move on over to the next one in terms of Luke. Luke presents a little bit different, although similar in a way that I inherited him a little bit later in the process. He's been an amputee for, well, it says 25 years, and he was in a crushing injury as well. Kind of a sad story with his brother when he was about 6 years old or so. But anyway, he had very short, bony residual limb. So very different process. He was in a pin for a while, had some of the same issues, and then transitioning him over to a negative pressure. In his case, it became more of a bony structure issue. He had medial condyle pressure all the time. So the clinician before was, trying to relieve that the best he can. And of course, once you relieve one area, then you're loading up other areas that sometimes can cause problems. So when we got him involved in the study, we wanted to make sure again that he was getting total contact, but at the same time, over the fib head, you can see his distal tibia is very prominent. We could do the same thing. The posterior medial condyle area was always kind of an issue for him. And even on the lateral condyle, just very bony structure. So in his case, again, you still want total contact, but there are areas that you want to have a little bit more relief in those bony prominences. And so we were able to do that as well. And going through the check socket phasing into the definitive, he was fit with several definitives prior to getting into the study. And the practitioner approached me and said, look, is there any way we could get him involved? Basically, again, for problem solving, because I mean, this clinician was spending a lot of time kind of guessing in terms of the pressure areas. I mean, you go back in, you'll grind the carbon socket the best you can. And in his case, I don't believe he wears a flexible inner, at least I don't remember he does. So there's certain limitations you can do to these sockets. And so, kind of chasing the fit. So we were able to, plug them back in, kind of start over again, recasted them, did a check socket. We were able to go ahead and try to, put the sensors in and see again, looking for total contact, but we were trying to relieve the excess pressure that he was feeling on the medial condyle, distal tibia. And again, Luke was just thrilled the fact that he could see it as he was wearing it and walking on it. He could see the pressure areas. And the remarkable thing is, you don't realize, through swing phase, how much you are getting drop away, even though our goal always as prosthetists is to keep that residual limb in that socket in the best contact you possibly can. But despite the fact that we did a couple of cases that had elevated vacuum, and so it was nice to see the differences between a pin system, negative pressure system, elevated vacuum system, that we could see the differences in terms of how much even the lack of pressure you're getting through swing phase and how much physically it's dropping away from the residual limb. So there's a lot of tools that allows us, and a lot of visualization that we're lacking otherwise. Again, we're always relying on patient feedback, on skin integrity, on our own skill set in terms of where do I feel like I should load or unload certain areas. So this takes the guesswork away, and hopefully it did relieve some of that, rather than 30 visits, you're down half of that or more. So with that being said, I think that's the gist of those.
That's great, Drew. Well, obviously, we're going to go through the results of the study that you've just been talking about. So I'd like, if I may, I would just drop you out for just a moment, Drew, while I just talk everybody through the protocol for the study, and then we'll go through the results that you've been assessing. So as we mentioned, we were looking to do an outcome study in the US with 2 clinics to understand really what the workflows for the professionals was going to be like, as well as what the patient experience was going to be. So you can see here, this is the protocol that we were working with and are still working with. This is the patient section, where you can see that what we're looking to do is to assess pre-installation of a new prosthesis, pre-fitting, and then obviously the stages thereafter. So if I just take you through the next stage of the protocol, for the patients, we were looking at effectively a 4-point assessment. The first one was really quality of life, which was assessing their mobility, their self-care, their ADLs, as well as mental health. And likewise, this EQ 5D 5-level outcome is probably more popular in Europe than the USA. But effectively what it does is it gives the patient a score based on their history, but also a score based on their feeling today. So that's a very good indicator of their general health and quality of life. The second is the important one for particularly in the US, the insurance market, which is the AMPRO test, which is the Amputee Mobility Predictor score, which helps us understand really what the associated K level is for the patient. So on the next slide, I'll just explain that in a little bit more detail for those that are not familiar with the K level. So 0 is basically where you have a patient who is really more or less bed fixed to a bed or a chair. They're not very ambulatory. Then likewise, as you can see, as you go through K1 to K2, they're going to be more active. And of course, the difference between a K2 patient and somebody who's a K3 to K4 is the difference of somebody being from a very inactive lifestyle moving into a more active and proactive lifestyle, which obviously can embrace things like not only extreme sports and running at the K4 level, but more importantly around the K3 level, which is actively returning to work and independence. So the K level is something that we were very, very clear on trying to identify whether we could improve that. And then there were some other scores that we went through. There's the timed up and go, which is probably familiar to everybody, which is from a seated position, going to a taped line 3 meters away and returning to seat to see if obviously the patient has got the ability to get up and be active and return to a seated position. But also from a let's say a commercial as well as a clinical perspective, is to understand the satisfaction of the patient themselves. You know, was it an improved process for them? So we've got some details on the first cohort. Just to finish off, this is the outcome. Just so for those that are familiar with the system, it's the McGann score, which obviously, as you can see with the terminology there, is really very associated with the prosthetics field, donning and doffing, everything through to mobility and standing. So on the next slide, you can see that we've actually gone through 12 patients so far. 6 of those have gone through the post-fitting assessment, and a further 2 have gone on to the post-7-day assessment. And Drew's been running this study for us in the States, actually using an adaptation of the Adapttech Insight app to help us collect the data. And on the next slide, you'll see that there's a fairly interesting illustration of how we've gone through the pre-assessment to the post-fitting assessment. And those 6 patients that we've been through, I'm just going to share that data with you now, and then Drew and I can just talk about that a little bit. So as you can see here, we've got a fairly simple red, amber, green scoring process. So you can see that on the first line of each patient, you've got the pre-assessment, and on the second line, you've got the post-assessment. And effectively, you can see that we've scored the improvements or otherwise associated with each of those patients. So you can see that specifically on patient 1, that patient's K level went from a 3 to a 4, which is quite significant in terms of the devices that they would be using and the access to the different techniques and technologies associated with their prosthesis. And as you can see, patients 2, 3, and 4, they were a similar K level, and obviously patient 6 was an increased K level as well. But I guess that aside from the K level, what I was very interested in understanding was the improvements in satisfaction. And of course, when you see red on a chart, you have to understand what that's all about. And I guess that really, Drew, we were very keen to understand what that was. And it turns out that that wasn't really a drop in patient satisfaction. That was an adjustment to the actual technology that you were employing at the time.
Yes, that is correct. There was a patient that wanted to assess some different feet. And so again, it was from a curiosity perspective on our side as well, how much changes occur within a socket depending on the foot that they're wearing. And so we went from his standard foot to a running blade. And so that's why this anomaly occurred. And, again, it was very fascinating to see the fact that the blade just, as far as absorption was concerned, it was showing a difference in the amount of pressure that the patient was getting at heel strike. And it was being absorbed, more through the foot, which is what you'd expect to see. But again, we assumed that, but we were able to, visualize that with the system. So it was not the fact that he wasn't satisfied, because it was just something that we thought he had, several different legs that we made. And we kind of, from a curiosity's perspective, said, hey, let's test this while we're at it. And so that's what that's all about.
Right, got it. So obviously that's an anomaly to the data, but in general, your experiences over those 6 patients, do you feel that the system assisted you with the workflows as well as obviously the outcomes that we're looking at here?
Yeah, I think from a perspective of just, again, I've stated this before, was just the visualization. Again, we weren't guessing as much in terms of where I was going to make that relief. Obviously we had a good idea, but the fact is I could go in and make the relief on the check socket and then rescan, and then we can visually see, okay, that's the area I was looking at. So that was a really good, a tool to be able to do that, and start off with the check socket, and then if you're having a few areas that you're questioning, and you could actually, reheat the check socket up, manipulate what you needed to do, then go back in, place the sensors back into those areas, rescan, and then do another reading. And so the fact that we could see the difference from where we started was what was really making the fitting process more efficient. And then going into the definitive, we felt more confident, as did the patient. They felt more confident that we had the fit, because they could physically see it. We did our reliefs, we did the rescanning. And so sometimes I know maybe some of the patients will go, really, they're kind of questioning sometimes our motives when we feel like what we're trying to, help them, obviously. But this gave us a visual cue.
Excellent. Well, I guess that just one further question, Drew, before we just let you jump off. So obviously talking about the fitting process, now you've done a couple of patients that have continued through this process, through the 7-day and approaching the 60-day stage. How have they been getting on since the original fitting?
They've been doing fine. Again, I think just laying that foundation of the socket initial fitting, definitely helped. It helped us pinpoint. I know I'm being redundant on that, but sometimes again, we're kind of guessing. We have the patient leave the office again, have them go for a while and just double check things. But the nice thing about the study was that it forced the follow up. It's not that we don't do it, but at the same time, we had some empirical data that we could, really look at, and then we could see whether they were jumping up from K levels, which in one case we did, like Randall. I don't know if you wanted to go over specifically about Randall Ullman or not, but yeah, bottom line in his case is that he was struggling with his fit, and his confidence was not where it probably should be. He did have some issues. He doesn't have a lot of sensation in his residual limb, and he was always getting breakdown behind the medial hamstring, I believe is where it was most of the time. And so we had to be very careful through a clinical setting. The physiatrist we were working with, we just had to be careful with his fit. So we got to the point where we ran him through Adapttech, and we were able to pinpoint those particular areas, and we backed off that pressure over the medial hamstring, but still were able to transfer the pressure areas where we needed it to support him. And so then, he was able to heal up. He was, walking more. His confidence went up, and so then that showed, in the outcomes measurements, is that he was able to increase his wear time and his physical activities, throughout the day. So that,
Right.
in that case, we have some very, empirical data.
Yeah, that's good to hear, Drew. Well, we're going to do some questions and answers later. So thanks very much for your time on that, Drew, so far. So we're going to move on now to our second professional. So we are also working with another clinic in the USA. And if I could just ask, do we go to the next slide, please? Cool. Okay. Well, obviously, Cassie, you've spent a different approach to taking a different approach to working with the system and with your patients. Obviously, a little bit more qualitative rather than looking at the data. So, if you're happy just to take us through your patient case studies, we'll hand the keys over to you, and I'll catch you at the end of your presentation.
And so Leslie has that plastic artery that is located between his tibia and fibula that, with any amount of improper compression, has significant effects to his day-to-day. Every 2 hours, again, he's having to take his prosthesis off, kind of shake his leg to help the blood flow return, and then put it back on. And then also knowing that Leslie is not the most excellent management of his volume was something that we also wanted to address by using the Adapttech system. So he came into us, again, leg completely beat up, having this problem with the artery. And whenever I put my hand into the socket, you can feel that there's a channel for this plastic artery. You can feel that that's properly made and contoured. However, if his volume's not stable, then he sinks too low or is too high in his socket. And so that channel does not optimally reflect on his skin, right? So then he gets these improper pressures, skin breakdown, etc. So we first started by scanning the socket and having him walk and showing him the data of when he came in just wearing that 3-ply sock, right? So the amount of pistoning that he was able to visually see, you know, we can talk about it all day long. We can try to describe it to them, but it was like a light bulb went off for Leslie. He was able to see anywhere his leg was bright red. That screen was lighting up bright red too, right? So the next step we took was, I said, okay, let's put on a 5-ply sock because you can clearly see you're bottoming out, right? And so we put that 5-ply sock on, and again, the limbs showed a much more even disbursement of pressure. And then we had one of the sensors lay right directly on top of where his plastic artery was. So we were able to see, okay, how much pressure is he truly getting? So he needed a little bit of resistance in that area to help essentially kind of act as a valve too and allow for that blood to keep circulating, but not so much to where it would occlude and his limb would go numb, because he experienced a lot of numbness too and the pain associated with that. So with Leslie, the main takeaways were I was able to pinpoint exactly where that was in his socket to make sure it was being offloaded correctly. And then really a huge asset was the patient education that I was able to show him. And again, using a prosthesis for 20 years and never being able to see what it actually looks like to him was phenomenal. And so he was very appreciative of that, and it kind of clicked. And ever since then, I have not gotten any calls. He is doing well. He's wearing his sock ply much more efficiently now because he was able to get it. He was able to capture that visual cue and really, really understand how the effects of not wearing sock ply correctly. So I think we can move on to Pat's slide. So Pat is a sweet lady. She's retired. She looks over her grandchildren. She's a transfemoral level. And the issue Pat was having, she had two. One was just having a newer amputation. The distal end of her femur was still very sensitive to her with or without having her socket on. So whenever we put the strips in to assess her socket fit, we could see some of that lateral distal femur pressure. And so with alignment changes and with a few socket changes, we were able to really improve upon that. And I think that's the great part about this technology, is that it's not only an asset for these static fittings, but it's also a huge asset with alignment changes, right? So if I'm changing that knee rotation or I'm insetting, outsetting that foot, it's going to show, right? It's going to show in the socket really what I'm doing. And the feedback is so keen and precise as to where they're feeling those pressures. It's definitely an assistant for you, both visually and just lets you know kind of if you're making the right decisions So with Pat, she also had a shunt that was put in her leg. Her femoral artery collapsed. And so that stent, they did the surgery, and the surgeon requested that I offload that area, right? It's right in that anterior wall of your trim line. And I'm like, I don't want to lose my ischial containment. I don't want to lose my AP compression, but I have to give her a little more space in this socket. So how can I confirm to this surgeon that I have done that? How can I qualitatively show that we have made a change here, right? And how can my patient know that it's going to be okay, know that, we're not going to increase pressure anywhere, we're going to relieve that a little bit. And so we were able to do that very successfully with the system. We were able to show that we were still getting good ischial containment, even with opening up the anterior posterior dimension just a little bit to allow for that femoral artery to have the space it needed to heal properly. And so she was very, very successful. Again, she's a new prosthetic user, but being able to see her socket visually, understand ischial containment, understand, hey, why do I have pressure up in my groin region? What does that mean? What does that look like? It was a very big benefit to her. And I think a great part of the system is being able to show and kind of help explain the difference between pressure and pain also. Just because something's contacting you in an area doesn't necessarily mean that's a bad thing. Just because there's high pressure doesn't necessarily mean it's a bad thing. So being able to visually show them that has been more than I could ever explain in words. It's that socket, their picture, their images, their pressure points, and it really becomes a lot more real to them.
Great, thanks, Cass. Okay, so obviously a lot of people have asked us, on the basis of where we are with our products in terms of approvals and market readiness. Well, I can assure you now that the product is fully market ready and available. And we wanted to hand back to Fred and discuss a little bit more about the commercials on the system. So while we just swap out to Cassandra's audio, Fred, are you able to join us and just maybe talk us through the commercials, please?
Yes, sure. Let me just change. Okay. Yeah. So basically, the way we set up the model is that we start by selling what we call an initial pack. So that has all the hardware and all the software needed to start using the system. So it includes the scanner, the wearable in the different sizes we use with different sockets, a certain amount, 6 box of sensors, 2 of each size, also once again to be used with different types of sockets, and the software license and support for the first year. This has a price of £20,000. So then we have the different price for the different regions. Obviously, then the sensors have a limited number of usages. They tend to break down after a certain amount of usages, but they are still reusable, and you can use them with different patients because they can be cleaned with alcohol. And for those, we have also a price of £300 per pack, and we are actually working to see if we can increase the number of usages and make them more robust so they can actually last longer. The support and license that is charged annually after the first year, it's for £4,000. So this is because all the processing is done over the cloud. You don't need any special computer, any type of hardware installed besides the scanner, obviously the wearable devices, and an iPad. You run everything through the iPad app. You can check your results then also on a web app, and that's all you need because all the processing is done on our side. Then I think we can move on to the next slide. So one of the things, as Drew mentioned, that we saw that had a big impact, and we think it's very beneficial as well, is that the scanner is not only a part of the inside system and not only to be used as a fitting tool, but can also be used as a standalone scanner and to replicate sockets, for example, or get a digital record of the socket shapes. And we've seen that this is a struggle in some of the centers because you get an amputee that really needs to replace his socket, but they really like it and they want to keep it. So it's very difficult if you have to destroy it in order to make a new one, and then they don't feel like the new one is as good as the previous one. So this is a very easy way of replicating the socket very quickly and without having any issues with the actual socket. So you can do this if you have the full product with the Insight. You can still use the Insight scanner as a standalone product without any further fee. If you just want to acquire the scanner, and there is a different price for that we have here on this slide. The same model, you acquire the scanner, then you have an annual fee after the first year. And once again, if you want to start by having the scanner, testing it out, use it, and then further along you want to scale to the full system, we can then issue a quotation for the rest of the components required and adjust the price for the software license. So the idea here is that we have a system that is fairly modular and that you can scale up as needed. In terms of the process, the way we've done it so far is that once we get usually we do a demonstration, we have a little bit of a discussion around it. Once we agree to proceed, we'll provide a supply invoice, get a 33% deposit, and with that get a shipping agreement in place, send out the equipment. Once it arrives, we get another 33% of the payment. We do the full installation, the full training, supply all the documentation, and set up the start of the support and license package. And once it's all fully working and everyone knows how to handle the system, we do the remaining payment to complete the payment. With that, after that, for as long as the license is up to date, we will support as required with everything that is needed. We've actually developed our system so we can do most of the support remotely, but if needed, we can also support locally with our partners.
So there is a way in which we can elevate everybody that's participating in the webinar from being a participant to actually coming up onto screen and being able to ask a question. So what we're going to do is we're going to elevate everybody that's attending the webinar today to a participant level, which means that we will be asked to have access to your audio and your video. You don't have to say yes, so that's absolutely fine, basically. But if anybody would like to ask a question of us, we can do so in this session. So while we work that out technically, and obviously if you have any Amazon deliveries or dogs or kids in the background, you might want to jump onto mute. But I guess that one of the questions that I know that I'm asked a lot is about the certification in relation to CE marking and FDA approval. So Fred, would you be able to just expand on that a little bit for us?
Yeah, so at the moment, the product is CE marked and FDA approved. So we have all the certifications we require and all the regulatory path is taken care of. So the product is ready to be delivered on the market both in US and Europe.
Right. Okay. And I guess that obviously with the sensors that you showed us at the beginning, how many sensors would you normally be using within a socket?
So it kind of depends on the type of socket that you're using and the patient. But usually I think the most common we see is if it's a below knee, it's 4 strips. If it's above the knee, it's probably 8. It has to do more with the size of the actual socket, but those are the most common scenarios we've been seeing in the recent testing.
Okay, great. Well, I guess that I believe that everybody's able to ask questions of the panelists today. So does anybody out there have any questions for any of us at all? It looks like, Jeffrey Hall, I believe, is talking. Could we elevate Jeffrey, please? Hello, Jeffrey. I can hear some noise in the background now.
Hello, I have a question.
Thanks, Elodie. Yes, welcome.
Possible to use the pressure sensors without the 3D scanner?
No, so the reason is that the way we develop the system is that the sensors can be freely positioned within the socket, so you can position them in any way and any number you see fit for that specific socket, And for that to happen, we need to have a reference and we need to know where the sensors are. So we always need the scanner to detect, to have the shape that you're going to modify to act as a reference, and to detect where the sensors are located and how many they are.
I think we have Roberto. Did you have a question for us? I think somebody's pushing Roberto out. So, Fred, just while we're waiting to get Roberto back, what do the colors actually mean? Does red mean bad and green mean good? I mean, what do the colors actually relate to when you're looking at the outputs?
Yeah, so basically, as I said, what we are showing is a relative pressure. So we are showing a pressure in that point relative to the entire pressure within the socket. So red just means that you have more pressure in that area than in the other zones of the socket that you're seeing. So it doesn't have to be bad. If it just means that you have more pressure in that area. So what you have to look into is what type of socket did you design? Where do you want that socket to hold the pressure? Or what areas do you want to avoid pressure? And the areas you design to support the pressure should be red or close to that. The areas where you want to avoid pressure ideally should be blue or with a light green. So that's the idea, is that you can see the pressure distribution, not the actual absolute pressure in each point, because depending on the type of amputee, the type of skin, the sensibility and what amount of pressure is good or is bad will be different. So actually what we need to see is the distribution of those pressures, and if they are being delivered as you design the socket to deliver them. So.
Okay, and just while we have you online then, Drew, how did you find interpreting the visual information that you were being presented by the system? Was that useful to you?
Well, there was a learning curve for sure. I mean, at first I was not, quite aware of what Fred just said, in terms of just, that you're going to see redness. I mean, but it is relative pressure. So once I kind of got that in my thick head, I think it definitely helped to, as far as the fitting process going forward, I knew what I was looking at, and I wasn't that concerned, because we had a lot of patients say, "Oh, well, look, it's really, really red there." And I explained, and Sandra was doing a good job of figuring, explaining that too, is that you want to have pressure. There are certain areas where you're trying to load up, depending if you're doing total contact or a traditional PTB style socket, or just trying to capture more weight up through the proximal section of the socket versus distally, and then over bony prominences. I mean, same thing. So, and we were clearly able to see, once I got that concept and I was able to relieve certain areas, I over relieved just from a study perspective. There were times where I just really bubbled things, tried to really take as much pressure off those areas as I could, so I could see if it was reflected. And it was. I mean, it was areas that, I was just kind of toying around with a check socket. Well, that's what's nice about a study, is, we had the ability to kind of play around a little bit too. Now, in the real world, you're getting efficiency time is of the essence, but we had the ability to kind of play around a little bit, and doing that helped me understand what I was seeing in terms of the, pressure distribution.
Right. Okay. Yeah. Very good. Does anybody else have a question at all?
Yes, I have a question, Phil.
Please go ahead, Roberto.
Okay, thank you. So I missed the first 20 minutes of the webinar, so I might have been discussed already, but that I missed it. When you're scanning the leg of the patient, do you scan it with or without a prosthetic socket on?
Yeah, so we don't scan the leg of the patient, we just scan the socket. So what we are scanning is the internal shape of the prosthetic socket. So we place the socket inside the scanner and with the sensors, and then after that we get the sensors connected to the wearable, and we get the patient to use the prosthetic only after the scanning is done and the sensors are connected.
Okay, so is scanning with the scanner, scanning of the leg with the scanner possible, because then you can make a cross-reference between the volume of the leg when there's no socket around it and when there is a socket around it, or is that not possible?
So in terms of the pressures, in terms of the scanning, you only do the scanning when the socket is outside, is not on the patient leg.
Yeah.
And then the sensor part, it's pressure sensors that need contact. So you need to have the residual limb inside to see that contact. But
Yeah,
then you can do it either static or dynamic.
Yeah. Okay. And is there the whole system? Is it been designed to just evaluate check sockets or definitive sockets, or do you use it as continuous information gathering as well? So can you send the patient home with the sensors? That's my question.
So the current system, no, you can send the patient home. It has to be used in a clinical environment. I mean, you can go to the patient's house if needed, if you already have done the scan with the iPad and the wearable and do that gathering. But it works with both the check socket and the definitive socket. You just need on the clear socket, you need to apply a scanning spray on the inside or tape it on the outside so you can get the shape correctly.
Yeah, Roberto, good question. I mean, we did it both. I mean, obviously we did it from a check socket state on new sockets, and we also did it with definitives that people were wearing for a little while and having issues. So we did it as a diagnostic tool with definitives that were people were struggling in certain areas, and then we were able to, you know, conversely do from the scratch with check sockets. And so, and to allude to your other question, I mean, a handheld. This is not a handheld scanner where you would scan the limb, you know, to get your model. This is strictly, you know, starting off in a socket phase with and scanning that so that you can do it under weight bearing, statically and dynamically.
Yeah. What is the range you can reach where you can get information on the dynamic measuring? Because I can imagine if you have some athletic patients that are, you know, doing running or whatever, that you might want to adapt their sockets to that specific sport action they're doing. What is the range? Is that possible? Has it already been done?
So the range of distance between the wearable and the iPad that is actually receiving the data is about 10-12 meters. Okay. So and then as long as the iPad stays within their range, it's okay. It doesn't matter the type of activity. We have actually tested one of Drew's patients with a blade in the clinic, and it's completely different. It's very interesting because the profile of pressures is completely different. How fast you get the difference between the different phases and the relief of pressures once the foot hits the ground.
And I had to run alongside him. So yeah.
I was going to say, you need to be quite fit for some patients, Drew, right? Or get a car.
I didn't last very long. I didn't last very long, put it that way.
Yeah, but I can imagine you can perhaps put the iPad on the patient itself and let him do some actions, and then we get back that you evaluate the information you got.
Yeah, sure. Yeah, you can get the iPad with the patient, hit recording, and then you can let him run or do the activity for a while. 2-3 minutes usually it's enough to get enough data for the information.
Yeah. Okay. Now I've seen the prices on the webinar as well. Do you have any idea how many patients you should use the system on to get revenue out of it? So how is that done in the States, for example?
So what we have seen, we haven't done that in terms of the number of patients you see, but we've seen that in the normal type of practice in the US, and we have seen that with the number of patients that you would see in De La Torre or in POA, and it depends more on the number of prostheses that you have using the same system, because it can be used by different prostheses at the same time. At the same time, no, but by different prostheses. So you can see more patients, but basically in an average clinic in the US, you would have the payback in the first year.
And I guess sorry, just to respond to that. I mean, obviously, Drew and Cassandra, you've been using the system and had an understanding of how perhaps the fewer visits that you have per patient would mean obviously more patients you could put through. Do you have an idea of how many patient visits you've reduced through using the system?
Yeah, I think that I can easily reduce the number of visits. I would say in the fitting process, going from first check socket to definitive, you can easily cut that down by a visit or two. It kind of depends on your practice method, right? Like sometimes we will let people leave with a temporary socket for a day or two and have them come back. So it depends on your clinic layout also. I think that it has helped cut out a lot of the follow-up visits, right? With being able to show them the problems that they're having. If they can see it and understand it, then they're not coming back and you having to explain the exact same thing you explained 2 weeks ago all over again, right? And those follow-ups, those educations, we can't bill for that, right? We are just stuck, right? So I think in both ends, in the beginning, it can definitely help reduce and get that socket fit quicker, but I think on the back end also, and doing that patient education when they return for an issue that's very clear why they're having that issue, it's helpful as well.
Yeah, and I guess to respond to that question, that we are also doing an outcome study relating to prosthetic clinic practice as well. So we will be publishing that as we get through the end of this year, and obviously post COVID. I know we had a question from Jeffrey Hall, I believe. I think Jeffrey, are you online? Jeffrey, are you perhaps online or on mute? No. Okay. So sorry, does anybody else have any questions at all? I mean, I know that we're running over on time, but of course, it's a great opportunity to ask any questions. Diana?
Can you hear me?
Yes.
Yeah. Hi, I just have a question regarding the sensors. Would you be able to estimate how long does it last approximately, the strip itself?
Yeah, so usually you can use the sensors up to 8 times. So it's to do 8 different acquisitions. So the problem here is not so much the time that you spend using them, is the process of placing and removing the sensors. So up to 8 acquisitions is the amount we can ensure that they are providing good results and good information.
Thank you.
Great. Thanks very much for that question. Any other questions at all? We've got quite a number of people.
May I ask a question?
Please.
Excuse me, I'm not a prosthetist, so forgive me if I haven't understood the concept properly. I could understand the benefit in Cassandra's patients where you need localized pressure reliefs over a vascular graft or a sharp bone or neuroma, but I am not sure how this benefits a patient. Say we are getting this pressure mapping of the whole socket area, the residual limb during various phases of gait cycle, but then the socket we produce is a fixed quantity, fixed shape and material. So how does the variation gets translated into the different phases of the gait, whether it is walking or rough terrain or running, or does it have to be a specific interface system for this pressure translation to benefit from?
Thanks, Dr. Suri. I mean, Dr. Suri, I know is a leading rehab doctor, Fred. So perhaps you might be able to assist with a non-prosthetic view on that.
Yeah, so I think the idea here is that sometimes when you're just doing the static analysis, there is no problem with the prosthetic, but then once the patient starts walking, in certain points he starts feeling some pain. So I think it helps because sometimes the problem might be in a specific phase of the gait. So you might have a specific region that is too tight during a certain movement. and that was more of the view on that side. Obviously, then you try to accommodate the design of the socket to be as best adjusted as it can to try to be properly fitted throughout the entire gait cycle. Obviously, the socket won't be changing its shape, but as Cassandra, I think, explained very well with the case of Leslie, then you also with the volume changes, it helps to see the effect of having more or less volume so the patient can actually know how to manage their socks, because we know that there are a lot of patients as well that have a lot of volume variation throughout the same day or throughout the year, the different seasons, different weather, different food they eat. And with that, they can know how it should feel and how the amount of socks they should use throughout the year to better manage that without the need of coming back to the center and having people look at it and see what's happening and why are they suddenly feeling pain. I think that those are the main points.
And outside of volume control, like Cassandra touched on, is that we notice that patients, depending on the flesh and the amount of muscle tone they have versus just tissue, makes a difference when we were manipulating a patient to take a step forward, rock over the toe, so we could drive that tibia forward into the socket, and then also at heel strike. And so there is a difference you could see at swing phase. There is basically the pressure is taken off on everybody during swing phase, but right at heel strike, that's when all the floor reaction forces are being, brought back up into the residual limb. And so that's when you can really start to see the different colors and the different pressure areas going on in the socket. So like in the case of Ken, I had him just step forward with the sound side and really put a lot of pressure back on the toe of on his prosthetic side and trying to drive that tibia forward into the socket. And, if he really pushed hard, obviously he could increase that pressure, but I was able to at least see from the sensing perspective, from the sensor, even when he did that, there was still enough of a relief there that he may get some contact, which is fine. We're looking for counter forces all the time too, but not too much. And in the case of our other patient that was very bony, kind of the same thing. I had him, and Cassandra alluded to this too, as far as alignment. If I had him take a very varus step, very inset, very narrow gait, we could see those pressure changes going on over the fib head laterally, things like that. So it was, again, a useful tool to have them step in various ways so you could see the different pressure areas in the socket. And so some things we don't take into consideration a lot of times. Even when a patient loses volume and they're not socking properly, a lot of times we're trained to make a relief, right over the fib head. But, the class, teaching up at Pitt, I make sure the students understand that as a patient loses volume, they're driving further down in the pocket. So they need to do a teardrop. They need to relieve that fib head, just not over the apex, which I see a lot of students do, but drop that transitional relief down. And same with tibial crest, same with other areas, distal fib, because once they do lose volume and they drop into the socket, then basically, you're creating more of a problem. So you want to make sure that you have those relief areas properly done, from the get-go. And this is a tool to allow that.
Thank you.
Great. Very good. Thanks very much for your question, Dr. Surya. Are there any other questions at all?
Yes, I have another question. Have you ever tested the system with adjustable sockets? And I'm not sure if you're familiar with the RevoFit system. It's a system where you can cut panels out of sockets, and then you can adjust the stump volume, the volume of the socket actually, just to see what the effects are.
Yeah, I can.
Yes, sir. Go ahead, Cassandra.
Yeah, I have a patient that uses a Revo socket, and I'm actually planning on using the system with her on Monday when she comes in. And because the Revo socket, her inner flexible is still a complete cylinder, it's going to scan that just fine, right? Even with those pads, when you crank that dial down and get that compression, the strips, those sensors are so flexible that I have no concerns about it contouring in and around where the those pads. I have a gastroc and 2 on either side of the tibia. So I have no concerns about them being able to contour and get a good reading of her socket. So I think that maybe if you were cutting your interflexible and you had some gaps between the interflexible, which I wouldn't really recommend doing that because you're losing that total contact right between those reverb pads. But if you had that, maybe I would just put like a thin layer of tape just so you can get that scan nice and clean where those gaps in the socket are, just to make sure, because the laser goes up and down, right? And it reads all of the information. So just to make sure that laser's not going through the socket and giving you some type of abnormality, just a thin little masking tape over that edge will not really change your volume at all, you know, barely, not even a millimeter, right, in your scan, and give you a good impression without causing any issues with the scan itself. So I see no problem doing that. I mean, I'm able to get the sensors to lay really nicely on the medial flares of my brims for transfemoral sockets. So if, you know, it can take a lot of those flows and those contours. So I don't have concerns. But I'll keep you posted on Monday when I actually do it.
Yeah.
So.
Yeah, that would be really nice. Yeah.
I'm sorry, the Regal I don't see a problem with, but the CJ socket or the Martin or the Infinite, that would be, I think, an issue.
Okay, and then I have one final question. I've been reading some studies that when patients are wearing their prosthetic sockets for a number of hours in a row, that the volume of the stump will shrink because the prosthetic socket will push all fluids out of the stump into the body. Have you done any long-term measurements, let's say 2 hours or 3 hours, just to see if this is happening? Is that possible with the system?
We haven't done it yet, at least that I'm aware, but yeah, it should be possible.
I think it's absolutely possible. I mean, that information of volume change is absolutely occurring, right? I have had someone come in that hadn't put their leg on yet, and 10 minutes later of walking around the clinic, their volume has just dropped and they need 10 ply worth of socks within 15 minutes, right? So yeah, it's totally possible to do like a morning fitting and an afternoon fitting and have them come back and say, hey, okay, what does it look like at 4 p.m. today, right? Especially with patients that are on diuretics and different water pills and things like that. Big differences could be seen. So a study hasn't been done, but we could easily, you know, look at that and show a big difference occurring.
Yeah, but the system, it can also measure 2 or 3 hours in a row, so that you, without any interruptions.
Yeah, we can usually, for now, we don't recommend saving, at least being recording data for more than 10 minutes, because then the processing will take too long, and then probably the patient won't be moving for the 3 hours. And the idea of saving the data, at least for the dynamic part, is that you have a continuous movement. But if you can record the static analysis and leave the patient with the system for 2-3 hours and save all that information for sure. There's no problem about that.
Yep. Okay. Very
Thanks
good.
for your questions. Great, thanks, Leo. Very, very good questions there. Does anybody else have any questions, or if you'd like to pose your question through the Q&A system at the bottom of the screen, you can do so via text.
Hi, I have a question for specifically Cassandra and Drew. Would you be able to share your personal experience? How long does it took you to get to know the system and adapt it in your current work infrastructure? So how easy was this process itself?
Drew, do you want to take that first?
Sandra, you want to go first? No, follow up.
Either
Drew?
way, go for it, Drew.
Okay, all right. No, there was a learning curve for sure. I mean, I wish I could give you a definitive answer in terms of how long it took, but integrating the software and the hardware, and then understanding the scanning process, and making sure that I was doing it properly. A lot of it was my error at first when I was, having some issues, And so they were wonderful in support, and so they were in constant contact with us. And, if we had issues, we could just dial them up and say, hey, what's going on here? They did have a few, glitches on their side with the software, hardware, but, for the most part, it took a few, times to do it, to understand the process and making sure I was, setting up the check socket correctly, the sensors correctly, doing the scanning, and then, translating it over into the iPad and getting the wearables to hook up and to integrate. So I'm not saying there was not a learning curve, because there definitely was, but I don't think it was anything that would be detrimental, put it that way.
Thank you.
And just to add to that, Dana, of course, just before Cassandra answers, the software issues, of course, were when we were using the system for the first time with a real customer. So obviously those have all been addressed since that first teething problems that we had with Drew. And Cassandra, your experiences?
Yeah, I'd say the same. Drew and I were beta testers, right? Real life world, how does this apply in clinic? And so definitely there was parts when I said, hey, in the app, can you I think this feels more intuitive. And they're like, okay, yeah, that makes sense, right? So once we got through some of those just small nuances, it has been pretty easy to incorporate. In the beginning, I was having to make sure that I had enough time to implement it into my appointments. So those first few appointments that I had with using the technology, I just gave myself more time so that I wouldn't feel stressed, so that the patient, couldn't see my stress, right, of being like, am I doing this right? So I would say definitely on your first couple patients, get those easy ones, get those relaxed ones, get those ones that can sit in the clinic for a little bit while you go through the process, and make sure that you feel confident doing that, right? And then from there, it's just intuitive, right? It's like any technology. You learn a new foot, you learn a new knee that you program, right? The first couple times you want to save a little extra room for yourself, and then after that, it's pretty intuitive. It's pretty seamless. So.
Yeah, I agree. It depends on how tech savvy you are too. I mean, I have to admit, I've had to learn some of this stuff, and we have access to the master's students up at University of Pittsburgh O&P program, and so they come through as externs, and so I was able to work with several of those students and introduce them to the system, and they caught on really, really quickly. And so the nice thing is now not every facility is going to have this ability to do this, but it doesn't have to be the practitioner taking the scans. I mean, you can. We have a young lady who was doing all the testing, like. I would set up an appointment, and then she would do all of the intake testing and the L tests and tug tests and psych tests and all that, and pain scale tests, and then I would do the actual scanning, and then after a little while I got the students involved, and they were able to run through it fairly quickly. So I think it would be individually, from a different, every clinical site is going to be a little bit different in the application here, but you can get creative with it. You really can, and I don't think it's an issue at all in terms of the learning curve. And again, once you get it, like Cassandra said, once you get it down, it was, became, much more efficient. But you still have to, plan it. You have to plan it, for your patient management.
Mm-hmm. Great.
Does that answer your question, Diana?
Yes, it does. Thank you very much.
Great, thank you. Well, I know we're running at an hour and a half now, so I'm sure some people are getting a little tired of looking at me at least. So any other final questions before we wrap up?
Yes, I have several questions concerning the pressure sensors. First, are the sensors calibrated?
Yes, they are.
Okay, cool. And then what is the data acquisition frequency?
50 hertz.
Okay. Will you do someday independent sensors to measure pressure on very tiny points?
That's one of the requests we've been having, also because of trying to apply to upper limb, where you want to see smaller regions. So that's something we have in our mind, and we'll maybe have a look at it and try to do something. But for now, is not in our plans yet.
Okay. I have another question. Is it possible to use the pressure sensors for other orthopedic devices, for example, to check the pressure in a scoliosis brace?
Not at the moment, because of the way the scanner is designed is focused on scanning the inside of the socket. So you wouldn't get a proper model and a proper detection of the sensors if you use it in other orthopedic devices. But that's also a request we've been getting from other people, and that's something we are exploring. And it's possible that we will eventually do it in the future, but for now, no.
Okay. My last question is, sorry, I don't really understand. Do you already have the CE marking, or do you plan to have it in the future?
We already have both the CE mark and the FDA approval, yes.
Okay, good. Thank you very much for your answers.
Great. Thanks very much,
you.
Elodie. Those are really good questions. I'm glad you were here to answer those, Fred, as well. Okay. Any other questions before we wrap up?
Hi, I just have another question. So what category does the sensors that the strip falls into, like class 1 or class 2?
It's a class 1 medical device, yeah.
Okay, thank you.
Okay. Anybody else before we wrap up? I guess not. Okay, well, thanks very much to everybody that joined us today. It's been a very well attended conference, which is excellent. And of course, thanks Drew and Cassandra for helping us out today. It's been great to get all of your insights, and you can tell by the questions that we've had that people are very interested in your experiences. And thanks for dealing with the technical issues there, Cassandra. That was appreciated to get back in there. So great. Well, obviously, we're going to wrap up. We'll be making a recording of the webinar available for everybody, of course, and we'll publish that once that's live. You have our contact details there if you need to get in contact with us. So just remains for me to say thanks very much, and we'll be seeing you on the flip side of COVID. Thanks very much, everybody.
Thank you.
Very much,
Stay safe.
everybody.
Thanks. Bye-bye.
Bye-bye.
Stay safe.
Bye-bye.